Is it English or is it German? I think it's images. So we will try to show images, right? So we will talk through images. And why we do 4D CT imaging? What's the need of it? Of course, the number one need is to identify parathyroid adenomas in primary hyperparathyroidism, right? What is the second need of 4D CT? You have primary hyperparathyroidism, you have secondary, and you have tertiary hyperparathyroidism. Secondary and tertiary are because of renal insufficiency patient, this gland become autonomous. Whereas the primary, in which you need preoperative precise localization, the surgeon can go and make a small nick and then they can take the adenoma. So they want precise localization. 4D CT has overshadowed ultrasound and scintigraphy because of its high sensitivity. But number three reason why we do it, the surgeon loves it, right? It gives them such a good anatomical localization of the lesion and the neighborhood. So here you see this is a classic example of parathyroid adenoma on 4D CT. So you have to do first phase, which is the non-contrast. Thyroid has iodine, but parathyroid doesn't have iodine. So you need to have that. This is adenoma here. On arterial phase, 25 seconds delay, you have a enhancing adenoma with surrounding vascularity. And then you look for washout. So there is wash in and wash out. This is the typical parathyroid adenoma appearance on 4DC, 4DCT. What is the fourth dimension? It is your time, right? That's why it's a dynamic study. So this is the typical appearance. Okay, let's use the mouse. So what are the supplementary imaging features you can use? Sometimes you may not have this typical appearance. So remember, these are vascular lesions. So look for these polar vessels on CT as well as on ultrasound. And also remember, these lesions are mostly in parathyroid locations. And if you are objective, you can actually do the washout on these, although there is no standardized criteria. As we see here, there is washout of these adenomas. But the problem is, in 1/3 of the cases I show you, this is the typical adenoma, wash in, wash out. But here there is no wash in, but there is wash out. Here you see there is no wash in, no wash out. So this is type B and this is type C. So just enhancement is not going to help you in all cases, only in 1/3 of the cases. So you have to rely on supplementary imaging features. Sometimes the adenoma can be very, very atypical, like this one has a big cyst, although there is surrounding vascularity. Even there is calcification, so the devil is cursed by its own curse, because parathyroidism causes hypercalcemia, right? So this is the atypical appearance. What are the two things you have to remember? You have to differentiate why we are doing all this. It can be a lymph node, the ubiquitous lymph node, and they can usually have type C enhancement, like in this case. This was a lymph node, but in some cases it is very hard to differentiate. So you have to keep in mind that there can be lymph nodes. Here is a parathyroid adenoma which was pushed posteriorly by the large thyroid nodule into ectopic location in prevertebral space. Then the second thing you have to keep in mind, is it adenoma or is it something else? What is that something else? It can be related to thyroid gland. Remember, use your non-contrast images first, but sometimes it may not help. So you have two inferior parathyroid adenomas, and you can see here, there is a fat plane between right side and left side lesion. This turned out to be adenoma. This turned out to be ectopic sequestered thyroid nodule, right? So sometimes you can have difficulty, but still the study works very well. We are talking about above 90% sensitivity and accuracy. So another example of something masquerading a thyroid adenoma. As you see there, this patient is post-hemithyroidectomy and there is a nodule. Can this be a parathyroid adenoma? Well, on the scintigraphy you see this, there is uptake on the scintigraphy. Sorry, is my time running up here?
Yes, almost, but...
We're already 5 minutes?
Yes, that's okay. Just take another 1 minute or so.
Yeah, so this is, you see, this was called as adenoma. Actually, this is just normal thyroid tissue. So you have to remember these pitfalls. And then let me tell you, what is the interpretation approach? I use the glandular approach. So you saw the eutopic, normal location of the glands, that is eutopic. Then the ectopic, I will show the example. Then you have multiglandular disease which is primary. Then you have multiglandular disease in secondary and tertiary hyperparathyroidism. Then you have no glandular disease, and you have recurrent glandular disease. So let me show you some example. This is a multiglandular disease. 1, 2, 3, and 4. 4 hyperfunctioning glands. On imaging, you cannot tell the difference whether it's adenoma or hyperplasia, but this is typical for secondary or tertiary. All the glands are hypertrophic and hyperplastic, or they can be hyperplasia or adenomas. Then these are the different locations. So the other glandular disease is ectopic glandular disease, and these are the different locations of the ectopic glandular disease. And here, more commonly, we see here in the tracheoesophageal groove next to the recurrent laryngeal nerve. This is an ectopic adenoma. And remember the blur artifact. There is significant blur artifact from the IV contrast or shoulders. So you have to remember that that can degrade the images for these small lesions. So this is ectopic location. And one important thing I want to communicate to you, if the gland is tiny, the lesion you find is tiny, and the hormone levels, calcium is very low, actually they are highly predictive that there can be multiglandular disease. And this is a way you can score. So the lower this number, the higher the chance there can be multiglandular disease. That is clearly a paradox.
Could you go to the last slide, please?
Yeah, this is probably second last.
Okay, perfect.
Yeah. So here we see ultrasound negative, scintigraphy negative, but we found the lesion on 4D CT. So in about 80% of these negative no glandular disease, parathyroid scan 4D can really help you. And this is the meta-analysis of summary that 4D CT can do a really good job, but in uniglandular disease. Multiglandular disease, you can still have problem. You can do F18 choline or 4D MRI. We always believe supplementary and complementary multimodality imaging can help. So I think I'll stop here.
Great, thanks a lot.